He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Welcome, folks. It is the Stay Off My Operating Table podcast. If you're looking for something else, you're in the wrong place. We're circling Phil. Our guest today is, I think Brian was our very first official guest on the show. If not the first, he was very close to the first. We were just talking about it before I pressed record. A lot of water under the bridge. Dr. Brian Lenzkes, no longer a resident of California. We're glad to have you.
Hey, it's great to be back. I can't believe you guys got so desperate you had me come back again, but it's all good. Honored to be here. Thanks, guys.
Yeah, definitely. I am quite excited. Jack, it's funny. I was actually thinking he was our first guest as well. It turned out he was close to our first guest, but it's been well over 2 years since we had a chance to talk to Brian on the show. I've been lucky to see him once or twice in person during that time, and he's been doing lots of great stuff, making some changes in his life. Really excited to catch up and find out what he's been up to. So maybe, fill us in on some of the big happenings over the past 2 years, Brian, and then we can talk about maybe how metabolic health and everything else has evolved during that time as well.
Yeah, it's been fun. I got chased out of California. I love Arizona. A lot more freedom here to practice medicine. And those of us who may be considered off the beaten path or fringe before we can change the standard of care, I love it here. I go for hikes in the morning, go for mountain bike rides, break a couple ribs here and there, do that kind of stuff. But it's great. I love it. And so it's a lot slower pace than what I'm used to in California. But I'm actually still in California. I still have my practice in California, but splitting time between the two, edging more 60-40, 70-30 in Arizona. Still doing metabolic health and loving it. And it's fun because I'm in a new market here. So I'm meeting patients who'd never heard of Jason Fung, or they never heard of Ben Bickman. And so it's fun because it's not just people who've selected me. They're people who are looking for a new doc. And when we start talking about metabolic health and deprescribing medications and metabolic health, it's just mind blowing for people. And so it's fun. It's like Christmas morning all the time, just seeing their eyes light up and know that they have hope and that they can stay off your operating table.
Yeah, that I think would be interesting, maybe place to start. Talk about establishing the new practice. You have an in-person practice there. Maybe give us a little insight as to, obviously you had a great reputation before launching the practice, but are most of your patients local? How are you connecting? How are people finding out about this crazy new doc in town?
Yeah, for the first time, I'm probably going to do advertising after talking to Jack and realizing like, hey, you may be known nationally, but locally, people don't know who you are. So I'm just like a new kid. No one knows me here. So it's fun. There's some people who know, they follow the podcast or my other podcast, Life's Best Medicine or Low Carb MD. And yeah, it turned out really I was going to do online mostly from Arizona. And that's what I was doing because I have a ton of patients from California, a lot of patients from Arizona that were driving to California to see me. And as things work out, I was looking for a place I could at least rent a spot or kind of get entrenched somewhere where I'm not paying over all the overhead till I could build my practice because it's labor intensive and cost prohibitive sometimes. And lo and behold, my old partner from San Diego, who we practiced together for 12 years, we had a lot of respect for each other. And 8 years ago, she moved to Arizona. Guess where she moved? Right where I live now. So about in 2021, she contacted me and said, hey, how are you doing direct primary care? I have to escape the system. It's killing me. She was just getting inundated with patients and stress and not sleeping and all that. I was like, well, I can help you. I was in San Diego at the time. So I helped her, taught her all the ropes and everything I could. And then a year and a half later, I said, hey, I'm thinking about moving to your town. And she's like, you know what? If you do it, I'll jump ship and I'll get us a place. And she did. So we have a place now and we're sharing space and we get along great. We have a little bit different perspective. She's more on the plant-based vegan side. I'm more on the carnivore or low carb side. So it works out great because patients can decide where they want to go. And we can achieve metabolic health just cutting out the processed food and the junk. So it's been a lot of fun. So now I'm seeing patients live here. So it's fun that I do enjoy that patient contact and building relationship and all that. It's a little bit harder over Zoom. It can be done. Being able to have the flexibility of doing Zoom meetings, phone meetings. If I'm in California, I could do that one meeting on Zoom, and it works out great. We can have continuity of care, and I guess to go hiking in the morning, so it works out nice.
What I'm hearing, a better lifestyle as a doctor.
Yeah, it's one of those things. We all know this thing. Now it's hitting. We've been yammering on about this stuff for a lot of years, and finally it's starting to hit the mainstream, right? You're having the Cali means and Casey means bring it to the forefront. There's politicians for the first time ever talking about it, so it's exciting. And yeah, me going back, I was at a medical conference, and lo and behold, Ben Bickman is there, the king of metabolic health and insulin metabolism. And I said, Ben, look, and at that time I'm working 18-hour days, stressed out all the time. This is probably like well before the lockdowns and all that stuff when I was in my standard practice. And I said, Ben, if I want to live a long life, what do I got to do? And he goes, oh, Brian, easy, 5 things. He goes, number 1, don't be stressed and working 18-hour days. I said, okay, what's number 2? Get enough sleep. If you don't sleep, you're going to die before everyone else. I was like, I don't think I like your rules, Ben, because there's only 5 and I'm 0 for 2. He goes, yeah, that's why doctors die before everyone else, right? We die at a young age because of the stress and not sleeping and priding ourselves and saying, I only slept 2 hours last night. Look how great I'm doing. That kind of thing. Eat real food, cut out the processed food, eat real food, exercise regularly, don't smoke or drink to excess. And so when he said that, I thought, first thing I thought is I got to get out of my practice back there, my old practice in the standard care, because I couldn't help people. And you have 2,200 patients and you can't possibly provide good care. So it's frustrating because we all went into medicine to help people. And so when you're limited in that, it's frustrating. And so what I would do is put my sickest patients that were going to get diabetes or had poorly controlled diabetes before lunch, and I would just see them for an hour and a half, like my whole lunch break I would spend with them. But then I'd have to, as Phil knows, doing all the callbacks at the end of the day and catching up on notes and all that. I'd be home. I get home at 8:30, 9 o'clock every night. And then back in the hospital at 4:30 in the mornings. If I'm preaching metabolic health, I should follow that myself.
And I'll just jump in and, of course, say, man, you internists have such an easy life. You got to be out of the hospital for 7 hours. But so true. And of course, I think back to the way I was practicing surgery full time. And you're right. We are not good at following our own advice. And unfortunately, both of us before we were enlightened, we were trying to follow our own lousy advice, and it wasn't working very well for us. But we found new ways. And it's amazing how many physician colleagues you talk to now, who are trying to do the same thing, but they come to this enlightenment, right, about their own health and about how it affects their practice of medicine. And when we change our ways, I think I've found, and certainly would love to hear your perspective on this, we might be spending less time doing it, but we're better doctors. We're more effective doctors. We're more efficient doctors, I would say. And so we can deliver that same excellent care without spending all those extra hours that we would spend.
Yeah, it's so true. And to make your point, one of my patients was going in for a bypass surgery back in the day. And I'm expecting to get a surgery and it's not done. Next morning, I'm like, what happened? Why wasn't the surgery done? So I go in with the patient. I go, how come you didn't do your surgery? And he said, the doctor came in. It was like 7:30 at night. And I asked him, how long have you been here? He said, since 4:30 this morning. He said, you know what? Go home, do me first thing in the morning. How's that? I want you to get a good night rest. And right. I'm like, that's a smart patient, right? Everything went fine in the surgery. I'm like, yeah, you don't want someone who's been doing surgery all those hours coming in and cutting on you. So I thought but that says a lot about what you do. And I hate to say this, but cardiothoracic surgeons are some of the coolest guys around. Like, calm under pressure. They don't, not seriously. It is really true. And I hate to say that, but it's true, because I did general surgery rotations too. And I said, there's no way in heck I would ever do it. And then I go, if I hated general surgery, CT surgery is going to be worse. And these guys were all super cool to hang out with, nice guys. And I think they get live. I think when you're dealing with life and death all the time, it changes things. And maybe being able to schedule your appointment and not being in there called in at 2 a.m. every single day, that kind of thing. I don't know. It takes a toll on us for sure. So yeah, practicing this style of medicine, you're not going to see as many patients. But if I want someone to make me a t-shirt, if they're going to make 2 t-shirts tonight, that works. If I need 400 t-shirts by tomorrow morning, the quality is going to be lacking. And I think that's a problem with medicine. We're trying to get these poor doctors to see so many patients. And so they're working on efficiency and coding and all these things. And they forgot about patient care along the way. And that's the tragedy of modern medicine.
Well, Brian, I would love to explore for both for our non-medical listeners, but also for anybody who's in the healthcare business, your path, how you got from where you were to where you are now. And let me put some boundaries around this. I just saw this is a guy that I was in a men's group with, posted a note on X today, and he said, "Hey, assume you were a 60 some odd year old guy and you were fixing to go see an internist for the first time. What questions would you go about asking to find out if this guy," I don't remember the exact words, but the gist of it was that this is somebody you want to trust. And it got me to thinking about, I remember when we interviewed you, when I first met you, and I find out here is somebody who's in primary care who is confirming the worst things about primary care that I had ever imagined. And here and you're working in the People's Republic of California. And then I was absolutely ecstatic to find out that you had moved just up the road from me here in Arizona, completely changed your life, completely changed your practice. So what I'd love you to do is just describe what a typical primary care physician's practice is like, the typical person, terms of the number of patients that you actually have in your practice, the size of your staff, the makeup of the staff. You talked about what a typical day is like for you or was like for you, but then compare that to how you're practicing now.
So, Jack, that's quite a question, right? For me, I never look back. It's like you're jumping off a sinking ship and you never look back. You go, okay, look, I'm sailing on this ship. It may not be as seaworthy maybe to start with, but we're going to have to make it work. The problem was the way I would describe it was like running on a treadmill that was a little too fast for you, right? And you could run for so long and you could keep up, but sooner or later you can't make it anymore. And you know that you can't take care of 2,200 patients. If you do the math, you think if each of those patients needs an annual exam every year, right? That's 5 annual exams a year. I mean, a day that you're seeing, plus all the emergencies and traumas and work-ins. And so it's like being the pilot of an airplane that's going to take off. And now all of a sudden there's 22 people that you have to get on your plane, but you have no seats for them, right? They have to be seen. You got to take care of them. So you're going to have to figure that out. And so I think a lot of doctors are in that flying by the seat of their pants where they're so stressed, so busy, so tense. And unfortunately, medicine becomes that person who wants to be seen for a headache.
Well, I'm going to push back a little bit because this is important. I don't want to just be preaching to the choir here. Most people do not understand how many patients a doctor has to see. A typical primary care physician who's operating under the typical insurance model, how many patients you're going to have to see on a daily basis. So let's start there. How many did you have to see when you were playing that game?
I was averaging about 22 patients a day on average. Now I see about 6 to 10 maybe. So way more than less than half of that. But the point is, the problem is you can never plan your day. As Dr. Phil will tell you, you're planning on say, hey, honey, I'll meet you. I'll be home at 6 for dinner. And all of a sudden, 2 people have chest pain, someone has a headache, and someone's throwing up. And you say, okay, what am I going to make them wait? Send them to the emergency room, or am I going to take care of my patients? So it was out of that responsibility to our patients. Now, what happens is if you call me with a headache, I'll go, I can see it 2, I can see it at 4 o'clock. I have an opening, right? I can squeeze you in. I had nowhere to put people. And it was so frustrating because my patients will be mad at me. But my options were this: I could rush through everyone and see every patient in 3 minutes and see a bunch of more patients that day. Or when you're there, I could spend the time with you. Right.
Well,
but it's going to take longer to get in. And that's why the primaries are so frustrated right now. That's what they're up against.
I was going to say, even at 22, you were giving your patients more time than the typical PCP model.
Yeah, I'll tell you, for years, I spent more time with my medical assistant, with my coworkers than my family. right? How you think about that, really, even the weekends, you don't make up that time.
Yeah.
So you're spending a heck of a lot of time. And if you're in a stressful environment, it wears on you. Yeah, like these places where there's like overflow of patients, everyone's calling and it's hectic, and you were asking the patient demands I had. Like right now in Arizona, I really have two employees, me and my wife, and I have a medical assistant who I share with my partner over there, right? At my old office, I had a biller team. So they have 3 or 4 billers that worked for us. We have the person answering the first phone, then they send you to someone else. Then I had a medical assistant. So to get to me, you had to go through about 4 or 5 people. Now my patients can text me and go, "Hey Brian, can you fill my meds tonight?" Yeah, no problem. Done. That's a lot quicker. I could send it in, text message, done, and it's off my plate. So at the end of the day, what would happen is I would have, because I was so busy, if you work through lunch, guess what? How are you going to return your call? So my medical assistant would give me 22 people to call back at the end of the day after seeing people. So you realize it's a not, and then you have labs that you have to review. Then you have chest x-ray. Then you get a call from the specialist. Then you spend 2 hours on the phone arguing with the insurance company trying to get an MRI approved, right? And you don't have time. They put you on hold. Then you got to talk to three. Phil knows what I'm talking about. You have to go through 3 people to get someone to help you. And then they go, "Oh, can you tell me about the patient? I just told 3 people before you the same story. Do you want to hear it again? Why don't we record it? I'm just going to record it and play it back for you guys because it's the same thing I'm saying over and over. Being on hold, you hear this terrible music that cuts in and out, that kind of stuff. And you're trying to get home to see your family. So that's what we're up against. And people don't realize I don't deal with any of that now. Because if I want an MRI and my patient's cash pay and they have a high deductible, to go in to get an MRI, $350 for an MRI. Your copay on that is going to be about $600 if you go through a standard insurance company. So you start realizing, and someone just posted something, or my patient actually asked me about it, say on Twitter, if someone goes in and gets metformin, it's $3 a month for if you pay cash. But through insurance, it costs you like $12 for the same medicine. So what happens to the other $9? And the pharmacist is not allowed to tell you that, hey, the cash pays this. They're not allowed to say anything. They have a gag order against them. So the patient pays more, the pharmacist gets less, and the insurance company gets reimbursed the extra money. You go, wait a minute, there's a problem. So when you start realizing all these things, that we can do it way more efficient in a cash pay type environment. And when I say cash pay, credit card or whatever, not going through insurance, because if I want to get someone's MRI, it's going to take me 6 weeks to get approval, even if I know someone has a torn rotator cuff and it's clear they can't lift their arm. They say they have to do physical therapy for 6 weeks. So the poor person has to suffer for 6 weeks before they can get an MRI to say, "Oh yeah, you do have a torn rotator cuff," which we knew on the physical exam 6 weeks ago. And so when you see the crazy, especially when you're a primary care. So I'll just give you an example of a patient. One of my patients was snowboarding, broke her arm, went to the ER appropriately. She has an HMO insurance. They say, "You have a broken arm. We can't really do a lot in the ER, but we can wrap it up, send you home, get you into an ortho to do surgery." So I talked to the ER doc, who was very nice, got all the x-rays, got all the imaging, everything's done. She has a broken arm clearly in 3 places. And so I do a referral to ortho. She goes to the ortho office and they say, "Sorry, we can't see you. Your insurance won't approve it unless you go see Dr. Lenzkes to get that he sees it and writes a note." So the ER note's not good enough with a broken arm with x-rays. What else do you need? Like I called the insurance and they go, "Sorry, that's our policy. We don't change." So I was like, this is ridiculous. The poor girl's suffering and now we got it. So things like that. And you go, gosh, you're just trying to help your patient. Plus that's in the scheme of having 22 patients in labs and all this other stuff. So it's just not good care. In the standard model is just not good care. Here where I live now, the standard person to see a new primary is 3 months out. So when I call them and say, "Hey, I could see you next week," they're like, "What? Okay. See a specialist." Like it's incredible. We're in a disaster situation. It's like having everyone has a free bus pass, but there's only one bus. Good luck. It's going to take you a long time to get on the bus. That's what we're dealing with.
Yeah, and it strikes me how much of this, the difference is in your old situation, right? You, the doctor, weren't making the decisions. The decisions were out of your hands. How much money would get paid for each visit, how many patients you needed to see, what kind of, and having all these people. Whereas now you're making the decisions, right? You decide how much you want to work, what your time is worth. And you have this direct relationship with the people again that basically you can say, "Hey, this is what I think my time is worth. If you think it's worth the same and you're willing to pay me, great. And when you need things done, we don't have to go through all these layers." And outside of the decision to pursue medicine in a different way, to focus on metabolic health, just the decision to say as doctors, "You know what? we're going to start making the decisions again. We're going to decide how we interact with our patients. So much gets fixed just by doing that.
Yeah, and that's the point, is really, this is the fundamental problem, is the conflict of interest that we have. And this is what I was seeing. This is why I left the system, just because I sat down when I resigned from my job right before COVID hit. The head of the HMO sat me down and goes, Brian, do you know how much money you made last year? What's wrong with you? How could you possibly not be happy? I was like, we're not providing good care. And he goes, let's talk about it. How do we get you to stay? I said, here's the issue, right? I spent all these hours with this patient because I'm trying to prevent them from getting diabetes. And you don't reimburse me for that. You reimburse me for a 15-minute follow-up, and I'm spending an hour and a half for that patient sometimes, right? I don't get reimbursed for that, and I'm taking time away from my family. And I'm saving your butt a lot of money, because I know the number one diagnosis, the number one person who's going to end up on your table is a diabetic, right? Poorly controlled diabetic with metabolic disease. The one who's going to get amputation, non-healing wounds, dialysis, you name it, the number one user is going to be diabetics. So I said, look, I have 11 people that we took off insulin in 6 months. At that time, I think I had 56 or 64 patients that I could document. They were going to get diabetes, but we prevented it by metabolic health. And I said, I saved your system so much money. And he says, Brian, you cost us money, actually. I was like, how am I costing you money? He said, if they don't get the diagnosis, we don't get paid. We don't get paid by Medicare. And that's how the system works. So the sicker the patient, we had classes, everyone knows this is true, any doctor listening, to show you how to code.
You were the first doctor I heard say that.
It's true, though.
I've told
we had
this
for
story
primaries
over and over again, and it still just blows my mind.
We had mandatory coding classes because they wouldn't get paid. I get it. You're not going to get paid if you don't code. So you have to know how to code. But then would say, if that pulse is down a little bit, now they have peripheral neuropathy, and now they got this and this. Why? Because you get paid more. For me, my patients now, the healthier you are, the better off I am, because I don't have to see you every week. You're healthy. We come in and we talk. I had 3 patients this week. We're just talking, how's things? I'm great. Oh my gosh, I'm off all my meds. I don't need any refills. That's easy for me. And I love it, and I get job satisfaction. So if you look at the physician burnout rate, the physician suicide rate, there's a reason for that. The system is killing them. So then they're saying, we're going to get you counseling. We're going to have peer review. You could talk to your friends, and we're all drowning. How do we help each other when we're all drowning? Someone has to get to the shore. So as direct primary cares have gotten to the shore, and we go, hey guys, we can help you out. Come this way. And it's a threat to the system, because if I'm only seeing, I'll limit my practice to hopefully someday 400 patients, right? Then I can still have a life. I can still provide good care. And you need things done, I can take care of it. But then
fascinating. Yeah. What's fascinating about that is if your practice is 400 patients, that means that there's another 4.5 physicians out there needed to cover for the 2,200 that you were giving crappy care to before. So this actually creates demand for better care.
Who wants to be sick? But the problem is, here's the problem. The system has trained patients to say, just throw me another drug. How many drugs can I get? I have diabetes. I have erectile dysfunction. I'm depressed. I need a med for all those things. How if we just fix the insulin resistance, metabolic disease, and see how you do? And then you don't need a million pills. So people are actually afraid now when we deprescribe. I was honored to be part with Mark Cucuzella of writing the first paper on deprescribing medications. It had never been done before. And that was just a couple of years ago. Never been done before. Why? How can that possibly be? We're very good at adding, say, we know the side effects and this drug's in infra. But how do you get rid of medicine? How do you get someone off of insulin? We know how to do it now. We have the technology, we have the skills, we have the data. We know how to do it. So it's not like when I remember it, when I was slogging along, working those long hours, and I would hear chiropractors or naturopaths saying they can get you off insulin. I'm like, they're dangerous. They're going to kill people. That's dangerous. Now I realize they were ahead of the game than us, right? They understood if you get the metabolic health, you get the stress, all these 5 things I'm talking about, people do better. Who wants to be drugged up the rest of your life and be miserable and I see it all the time. People are in their early 50s and they have amputations from diabetes complications. I can't do anything for you now, but 15 years ago, we could have prevented that. We have 15 years before you get the diagnosis of diabetes. In my opinion, if someone gets diagnosed with type 2 diabetes and the doctor hasn't warned them at least 5 times, the doctor is committing malpractice. It doesn't just happen one day. You don't just wake up with diabetes. We have this insulin goes higher and higher to your pancreas can't keep up anymore. Ben Bickman's has tons of graphs showing this. And you say, wow, if we just intervene early. So when that doctor's telling me that I'm costing the system money, I think, you know what? The system got to be changed. It cannot function, the sicker the patient is, the more I get paid. Could you imagine if you have a financial advisor, the more money your client loses, the more you get paid? Oh, okay. That's not a very good. You want them to say, hey, if your patient does well, you do well, right? That's how it should be. And direct primary care is that model. That's how it works. You say, oh, if you stay healthy, I get to go home and see my wife tonight. I don't have to do chest compressions on you tonight. So those kind of things you look at and you go, okay, like we can do a better job. But we have either, you can look at it one way or another. We either have a shortage of doctors or we have an oversupply of sick patients, or both. Right. So unless we get people healthier, because if I get my 400 patients healthier, guess what? Their insurance should love us because we're not costing them money. We're saving them a lot of money. They're not even paying, we're not billing insurance, right? So we're not costing them anything. All we do is benefit them because a lot of these people have insurance. They say, I just don't trust the doctors on the plan.
Oh, isn't that interesting?
I can't get in. It's incredible. It's an incredible problem. And then what's happening, I'll tell you, the other big problem, and this is what happened to my partner here in Arizona. What would happen is you're in a HMO plan at this office, you have 5 doctors, 2 of them quit. Who's going to take care of those patients? The 3 doctors that are left. So they're hammered even worse, and it gets worse and worse. I go, you don't like it, go somewhere else. And so finally she said, yeah, I can't have a picture of my husband in my own office, not on the exam room, but in my own office. I can't have plants. I can't. And they make all these restrictions. You go, this is crazy. Like, how are you going to, when you're miserable, how are you going to be a good doctor? It goes both ways. So I can guarantee you, Phil, if he's not sleeping at night, he's going to be grumpier than if he gets a good night's sleep. I'm sure he doesn't get grumpy at all, Jack.
Oh, I'll tell you what, he's an absolute pleasure to work with, but
not anymore.
I'd love to hear 2 years ago when we first spoke, 2.5, however long ago it was, I was just starting to get introduced to this whole metabolic health world through Phil. And it's been so much fun to watch over these last couple of years, the massive shift that seems to be taking place across the board. And I would start with Robert F. Kennedy Jr., the place that he has established himself in the consciousness of the Republic with his Make America Healthy Again. 2.5 years ago, it was inconceivable that a message like that would resonate. And yet here he is providing a significant part of the campaign of a presidential candidate. And I can't help but think it's people like Phil and like you, doctors who have said that old model ain't working. We have paved the way. I'd love to hear you just talk about how the entire environment has shifted.
It's wild. This will be a trip down memory lane a little bit, but at this time, there's a few years back, Phil, I can't remember how long ago it was, but we were in Boca Raton and I didn't know Phil, and he's there and he has this huge stack of red meat on his plate. And I look and I'm like, hey, is your cardiologist get mad when he sees you or what? And I didn't know who he was. I didn't know. He goes, yeah, they don't like me very much. And I go, so are you a doc? What do you do? He goes, oh yeah, I'm a cardiothoracic surgeon. I'm like, you're kidding me, right? And he has this huge stack of red meat. And then Sean Baker, who I've become friends with over the time, God rest his soul, on Twitter, they said he died today. But
who allegedly died today.
Yeah, he looks pretty dang healthy to me. And I saw his video of him addressing it, so I think we're safe. This guy's a beast, right? And I go, okay, it's a fad, but let's see his coronary calcium score. And it was 0. And I'm like, okay, it's probably legit. So to see a cardiothoracic surgeon and doctors who I respect, Dr. Phil here is you. It's not the other Dr. Phil. This is not the psychiatrist Dr. Phil, or psychologist, whatever he is. But saying, hey, look, I can make you healthier and I don't have to do surgery. He's going to make way more money off you than by doing surgery on you on his table. That's where he's going to make his money, right? So preventing you from ending up on his table, that's going to give him job satisfaction more so than having to open your chest and make you miserable for the next 6 weeks or 6 months, whatever it might be. Gary Fettke was telling people not to eat sugary stuff and get their sugars under control, but he was making a lot of money amputating legs, but he would rather help the patient, right? Jason Fung, who's a nephrologist. The best thing for his business is everyone being diabetic and going to kidney failure, the number one cause of kidney failure, right? So all these guys are taking a financial hit to help people, right? Writing books, you don't make $1 million writing books, right? So doing stuff to get the idea out and the message to help people, that's the reality. And so that's where it's changing. People are realizing, hey, if Sean Baker could be eating red meat all the time, maybe that's not the problem. Maybe there's something else we have to look at. And when I asked Phil this question, he said, look, I've done a lot of bypass surgery on people. A lot of people had normal LDL cholesterol that I did surgery on. None of them had normal insulin levels. And when we look at the data, that's exactly true. Right? High insulin level, insulin resistance, this whole metabolic syndrome, metabolic disease, it's well documented in the research. Some of the big governing bodies, and this is where Kennedy and some of the people who are questioning this are saying, who's sponsoring you? Who's paying you your money? Because if half my money is, if you guys are paying me to come on the podcast, I'm not going to say bad things about you. So there's a lot of conflict of interest that's coming to light. And some of the stuff we've been talking about for years, Jason Fung has been on, really called this stuff out. He has a lot of integrity. And he goes, look, we just saw something this week. $1 billion got paid to peer reviewers from pharma who just, they're deciding whose articles are going in these journals. And then if you get a medical journal, you look at all the advertising for all these drugs that are throughout the whole thing. Like you can't even read a whole article without having advertising in there, right? Over and over. And that's not free. So these things you have to look at and go, oh, who's controlling this game? And again, as primary cares, we're not allowed to take a pen from pharma because it would alter our prescribing habits. Because if this said Viagra, I'm going to say, oh, all right, Viagra for this person. But they take $1 billion and no one bats an eye. It's incredible.
Yeah, it one of the things that's been so interesting about what Robert Kennedy's been talking about and Callie Means and Casey and all of this that is coming to light, it really is unbelievable. Some of the things you just said, to realize how much the system is conflicted, right? And it's always interesting, right? On social media, as doctors, oftentimes you get the attack, oh, you guys are getting paid to prescribe all these medications and stuff. And it's, no, none of us really, the average doctor isn't making any money to prescribe these things, but the layers above them, the money that goes into that, and the controlling the information environment in healthcare, that's where the money goes. And like you said, the pharmaceutical companies, it's not the individual doctor that they really try and control. It's the information environment. When it's from the medical schools and the journals and just every source of information that doctors get exposed to has been corrupted. And that's where the problems lie. The average doctor has no chance, right? Because they don't see outside of that bubble that's been created around this information. And when you start to peel it back and you do start to look at it, it is amazing. It is. And quite frankly, I think for the average person, it sounds like, no, there's no way that can be true, right? It's too unbelievable that the system is that conflicted, but it really is.
Yeah. And that's the point, is we have to discuss these conflicts of interest, right? It's public knowledge that some of the big healthcare plans were giving bonuses to doctors based on, one just had something where the more patients you saw in a day, the more that you would get acknowledgements and bonuses, and you're rewarded for being a monkey, just getting it. It's not about the quality of care, it's about how many patients you could see in a day or a week or a month. And so that's dangerous. And then the doctors' bonuses at the end of the year. Did you prescribe this many drugs? Did you do this? Did you? And that's what you're based on, not how many people do you take off insulin. You don't get a bonus for that, right? So when you start looking at the conflict of interest in these problems, and you're right, Phil, we never made a dime for prescribing a statin drug, but what happened was the thought leaders, when we go to those dinners, right? I have friends who are cardiologists and they go, oh my gosh, this is great. I get paid a lot of money to go give a talk, and I don't even have to make the slides. They make them for me. They tell you what to say. You're reading a script. So for me, when I go give a talk, first of all, I don't get paid for those talks. Second of all, it takes a lot of time to do the research, put the slides together and all that. They go, here you go. Here's your slides. You just go give a talk. And so it's the generals who are paid off, not the infantrymen, the people fighting on the front lines. But you're getting your marching order from these guys who are getting paid, right? And it's even worse than that. A lot of these guys, now it's become public knowledge, is that a lot of people on social media, influencers, doctors, and they're not paid by pharma. They're paid by the PR firms that are represented by pharma. So pharma's paying them, and it's a money laundering scheme. They didn't pay me. If I get money from Jack, I'm like, Phil didn't give me the money, Jack did. So it's when you see those things and you say, wow, why would everyone attack that one doctor about metabolic health? And the metabolic health doctors are the ones under attack all the time. And I could tell you, speaking for my part and Tro's part, we self-funded. Like we settle up at the end of the year after having however many million downloads on Low Carb MD, right? I do have sponsors for Life's Best Medicine just for production costs. So I don't have to pay out of pocket. So they're nice enough to help me. So no one's making millions and millions of dollars by leaving the system, right? I'm probably making less money than I did 5 years ago. But guess what? My wife is happy that we both just were interviewed on Boundless Body separately. And it was amazing to hear her story. Like, it was touching to see that she has her husband back, that we can say, I'm not in a hurry and rush. And like, we didn't have coffee. We have coffee together every morning now, right? Back then, I was getting up at 4 in the morning. I'm not gonna have my coffee. My wife wake up at 4 in the morning with me to have coffee. And so all those little times watching the sunset, watching the sunrise, the joke at my old neighborhood was they go, Doc, why do you even wash your car? We never see it in the light of day. It's always dark. You either leave in the dark and come home in the dark, right? That's not the life any of us wants to have. A prisoner has a better life than that. That's why I have compassion for doctors that they're stuck in the system. And anyone I can help get out, I love it, because they'll call me and go, Brian, you saved my life. That's why I feel with Jason Fung and all these other people. Tro goes, what are you doing, man? You're killing yourself. For what? Because at some point, those patients aren't going to your funeral, right?
Mm.
We have an obligation to our patients, but you know what? The reality is it's their insurance changes and they go to the new doctor. So why do you have this sense of that you're the only one who could do this, right? And that's what I had to come to terms with and realize I'm not indispensable. But in that system, I wasn't a good fit anymore, because when you reward, I spent years trying to figure out how to be more efficient, but not more effective. Now I'm more effective, right? I'm a lot less efficient because I don't have to be efficient anymore. I got an hour to spend. What do you want to talk about? Let's go through this. And so we can, in an hour, we can change, we can save someone's life. That's the reality. I have a guy, I just took him off 2 meds where it's just incredible what we can do, but it takes time to really ferret these things out. And that's what we have now. If someone could sit down with you and pick your brain for an hour, that's a huge deal. That's a huge deal because you can give them a lot of information and keep them off your operating table.
I would like you to talk to the healthcare professionals who are stuck inside a system. They recognize exactly what you're talking about. Because they live it, and you managed to get out. How do they get out? Let's be painfully honest about what it takes to return to being a healer rather than merely a representative of the pharmaceutical companies.
Yeah, I'll be professional and say it takes courage, right? It takes a lot of courage. It takes a lot of courage to stand up and go, look, I had to sit down with my wife. When I resigned, I called my wife and I said, oh my gosh, I think I just resigned because I had it. I'd had it. I was working too many on, and all I wanted, my only request was, hey, can I bring in a PA or a nurse practitioner to help me? Because I don't need to see everyone with a cold. I'm working tons of hours. And they're like, you make so much money, Brian. How are you complaining? I'm like, I can make a ton of money, but I'm never home. I can't go on vacation because if I go on vacation, I'm stressed for a month before I leave and a month after I get back. I have no quality of life. I could have money in the account. My kids will spend it when I'm dead. So at that point, you start realizing, oh, we got to fix this system. So I took a pay cut for sure. And of course, I jumped ship right before COVID lockdowns. It ended up helping me though, right? Because no one wants to go into an office with 50 people sitting there when you have a deadly disease floating around. So I can see one at a time. You come on in, I'll see you. We'll hang out. I'll get you taken care of, and you don't have 30 people. I joke with my office managers like, why do we even have a couch? It's just for looks because no one sits on it. They come in unless they want to sit and talk to her for a while after their appointment, but no one's waiting, right? You're not in this overwhelming, stressful environment anymore. So for someone to jump ship, it takes a little bit of financial security. And the reality is this: these doctors are hostage. When I graduated, I had $380,000 in med school loans and cost of living. You don't have a job and you have to live for 4 years. Plus you're accruing interest that entire time. So by the time I paid it off, it was well over $500,000. Do you think in that system, I'm going to be able to jump out and be able to start my own practice? No way. So I was fortunate enough because for me, it wasn't as much of a risk. If you have 2,200 patients and you don't get 300 patients to follow you, you can't be that good of a doctor. So but to tell people, oh, you don't have, now you have to pay me a monthly fee now, but I'm available. There's a benefit, right? There's a difference between having a doctor and having them available. People listening will know. As a matter of fact, one of my new patients, she goes, here, call my old doctor's office and see what you get. And it says, okay, leave your message. We got your message. Don't keep calling back. That's just going to delay things further with us getting back to you. So what does that tell you? That tells you they're getting a lot of calls and they're not getting back to people. Why would people keep calling other than if you call them right back, they don't have to. My patients don't call me a million times. So I think in reality, you have to look at that. And for me, the reason I didn't get out sooner was because I wanted to prove myself and I wanted to work hard. I wanted to climb up the chain and you want to provide good care and do all these things. But sooner or later, you think next year I'm going to slow down. Next year, then you don't. Then it's 10 years in. I was 17 years in and I never took a breath. Right. And if you're good, you're busy. Right. So if a doctor has a lot of free space, you go, why does that doctor have a lot of free space? They shouldn't, right? They should be really busy like everyone else. It takes a lot of courage in saying, okay, can I sacrifice? Right. For us, it's painful as it is. It was a blessing in disguise in that my old practice in 2011, they had an embezzlement from the office manager, $500,000 gone. So I didn't take a paycheck for a couple of months, and none of us docs did. And we had to take care of our staff and all that. And I thought about it, like, I went 2 months without a paycheck. I can go another half a year without a paycheck if I had to. I could survive. Guess what? I don't need cable. I don't need to have a fancy car. My wife and I are cruising in the Riviera all the time. So my cost of living is low. So it's like, you know what? If I can enjoy it now, I look back and go, man, I don't even look at what I'm making compared to what I used to. But to be able to go for a hike with my dogs and my wife and throw rocks and waste time and do things, like when you're under chronic stress, it's just not good for you. And we know that. We have tons of literature on that. But we subject ourselves to, and Dr. Phil will know, it's okay. I don't want to live like that. I don't want to be bitter at the world and not enjoy life. And when you're up and working hours that are crazy, the money is secondary for sure. You start realizing that's why I started Life's Best Medicine, what really matters. And I don't talk to anyone that says, oh yeah, the most important thing is money. I just heard, it was sad. I was looking at this. I was watching this thing about the Gucci family, and there's one of the wives who married into the family. She said something to this effect. She said, and she was miserable. No one liked her and she was miserable. And so she said, I would rather cry by myself in a Bentley than be happy riding a bicycle. And you go, you got your life priorities out of whack, right? Like I always thought you'd rather sit on the floor and have a hamburger with your best friend than eat in the best restaurant in the world by yourself. So I think a lot of doctors forget that. And a lot of us, my personal relationships suffer. Like old friends would say, hey, I haven't seen you for 2 years. I'm like, I'm just busy, man. I don't have time to drive to Orange County to have lunch. I never took a lunch break at my old office. Never. Maybe 4 times in 17 years that I would actually leave the office for lunch. Because if you left for lunch, then you'd be working until 10 o'clock that night, right? It was never a thing. And when I went direct primary care one day, like I was in there for 30 weeks or something like that. In one day, I had my youngest daughter, my oldest daughter, my wife all come visit me. Like I had never done that in 17 years. Like to come visit me at the office, and I had time to sit and talk to them, right? And you go, oh no, I don't have time to talk. I'm too busy. So being busy all the time, there's no money in the world to give you a little free time, right? We're hostage. Phil, I'd love to hear your take on that. I'm sure you agree with me.
Yeah, and I'll go beyond that and say I'm still quite busy, but I'm less stressed and I'm happy because we're getting that job satisfaction like you talked about. We're practicing better medicine. We're seeing better results from our patients. And of course, I am still operating and I have the practice and all the other stuff I do. So it really, for me, it's not about being less busy per se. It's about just having better job satisfaction, and that control that we talked about. At least I'm making the decision about what keeps me busy, right? And I'm making that decision about, am I going to do this or not going to do this? It's not someone else making the decision saying, you have to be busy, Brian.
Yeah.
And I think that's really a factor that that doctors don't understand, how much control we've given up in the whole system. And we no longer get to decide, because it's one thing to say, yeah, I'm okay working, I'm okay being busy. Just I want to be busy at things that I choose to be busy at, that I know are going to benefit my patients and are going to have beneficial effects on the world around me, rather than just benefiting whoever's above you telling you what to do.
Yeah, so true. Having that freedom, that's a huge point. That's it. I don't work a lot less hours necessarily. I actually do, but I still work a fair amount. And people go, are you looking forward to, like my neighbors here, most of them are retired, go, aren't you looking forward to retirement? I'm like, no, I'm having fun right now. Look at Dr. Unwin. He was on the way to retirement because all of his diabetics were getting sick and dying. Now he loves what he does. He's not letting the accelerator off at all right now. So when you see people like that, you go, I enjoy it. I love, this is our calling. This is what we went to do medicine for. We didn't do it to check by. I was like, this is crazy. I remember just sitting there every day going, I have to check this box. If I don't check this box, I don't get paid. I check this box. And it has nothing to do with patient care, nothing. But they go, you didn't check this box. And with Medicare annual exams, you don't even do a physical. It's not even a requirement to put a stethoscope on the patient. But you have to ask them, have you fallen down? Or do you have a gun in your house? Are you like all these other people are like, why are you asking all these stupid questions? Who cares? Can I talk about my chest pain that I'm having? Well, no, that's not part of the exam. We can't address actual problems. You know what I mean? So it's crazy. The system has gotten so nutty, and people out there will know what I'm talking about. I just had a new patient to me, and she said, I addressed all of her. She's, I can't believe you addressed all my stuff. And I go, why not? That's what you're here for. And she said, I just went to urgent care, and they told me she fell down, hurt her knee, and had a urinary infection. And they said, which one do you want to treat today? That's like going to the mechanic with a broken down car and go, okay, we can either fix it to a transmission or the radiator. Which one do you want to do? Well, it's useless to me. I can't fix them both. So yeah, it's amazing. So that's why we smile a lot more. I think we smile a lot more than we used to, because when you're stressed and tense, oof, and I can't even imagine being a surgeon. Like you have to keep your hands clean and stand like this, and you can't touch anything, and it's too stressful. Little tiny bleed that you're looking for, man, I don't want to deal with that in my life. I'll let smart guys do that. Yeah. Those little sponges, and you're counting them. I'm like, how long is it going to take them to count all these things? Right. But it's important because you miss one and the person dies. Right? So it's important stuff. I don't have time to count sponges. Right.
I'd love to hear about how you and Tro got connected on this podcast.
Man, just bad judgment. No, I saw Tro on social media, and I was seeing some of the stuff he said. I'm like, oh, this guy's he's a New Yorker. I'm a California laid back guy. And he was saying he doesn't hold back, right? He's the Jerry Springer guy sometimes on social media. But I saw him post one thing, and so I knew I actually was fortunate enough to be on the Two Keto Dudes podcast. And they said, you should have your own podcast. And they said, we'll produce it. And it was going to cost me like an arm and a leg. I'm like, no, thanks. I'm not. And I didn't think I was the personality to host a podcast by myself. So I wanted someone else. So I see Tro, I'm like, I saw his story. I go, this guy has a great story. He's lost like 250 pounds. He's running now. He's taking care of himself. He did it all. Even after he was a doctor, he knew what to do and didn't know how to help himself. And so I'm like, this guy's a great guy. And then I saw him say something like, oh, I don't know. And then I saw him post something that, and I go, this is the guy. Because he said he was running on the treadmill. And these two guys behind him said, look at that fat guy. Why is he even here? He's wasting his time. He's not even in shape. Why? Like, no one wants to see that here type thing. And he got embarrassed and thought they were talking about him. He started to leave, and he had already lost 200 pounds. And he realized, oh, that's not me they were talking about. But he was making the point, these things don't go away. This stays with us. And I go, that's the guy. He gets it. And this guy's lighting the world on fire. He's doing way more than I'll ever do. And he's young and has a lot of ambition, and he's working hard. And so it's been a huge blessing working with him. We get along really great. And at first people thought we didn't, because we rib each other, but it's all in good fun. We love each other's company and all that, and our wives get along, and yeah, so it's really great. And actually, who knows if we'd be here right now? But what happened is I had crossed paths. Jason Fung was a huge mentor of mine. So I said, hey, Jason, I'm thinking about doing this podcast, and we were going to call it Two Keto Quacks, because everyone said that back then that if you're doing keto, you're a quack. So we thought it was funny. We thought it would be like tongue in cheek type thing. And Jason, no, you guys want to be taken serious. You got to think of a different name. So we brainstormed, come up with a low carb MD. And it's funny because Tro's a DO, and I even think about it. So anyways.
I didn't realize that.
Yeah. And Jason helped us get off the ground. And I said, hey, Jason, would you do us a huge favor and be our first guest? At least you'll get us some listeners, and some people decide if they like us or not. And Jason said, I want to collaborate with you guys. I want to do the podcast with you. Really? Okay. But he didn't like interviewing people. So he likes to be interviewed, not interviewing other people. So he said, guys, you guys just take it and go. I'll see. Because he had so much stuff going on too. But he's just a great, super great mentor and great guy. I have a ton of respect for him. So that's how it happened. We started doing this thing, and it just caught on somehow. And then it got bigger and bigger. And we're like, oh my gosh. It was actually Jason who cursed him a little bit. He said, look, we're not going to take any, because a lot of people said, we'll sponsor you guys. And Jason said, no sponsors for this podcast. He was the one who put his foot down. And so Tro and I, like, every year we had to settle up. I go, Tro, how much do I owe you? You owe me $800. I'm like, oh, gosh, this is killing me, man. Just for production costs and all that stuff. So luckily our Patreon, and I said, Tro, if we can't do it with Patreon supporters, we're not meant to do this. And so it's a tiny percentage, but the Patreon supporters are huge. They kept us going, because I was going to fork out of pocket when I left my own practice and making half the money I used to make. So yeah, it's been a great journey to see that people were invested in chipping in and helping. And we even discussed, we go, gosh, we made such a big deal about not getting any corporate interest, but would we do it if it was someone that we believed in? But we decided not to, and it's been good. Our Patreon supporters have supported us. We don't take, and by the way, we don't take any money ever. We never taken a dime. If we have 1 year, we had extra money left over, I think, and we sent it. We volunteered, donated money to our favorite charities and things like that because we made a commitment. That's what we. It's important for us to get the message out. So it's nice not having to pay money to get the message out. Yeah. And it's helped us, of course, like word of mouth and getting known a little bit and those kind of things. And so it's good. It's been a huge, but the other thing, as you two both know, you get to talk to the best people on earth, the thought leaders and the people who like sacrificed everything. And every time I interview someone, I get little pieces of them. So it's amazing that we get that experience. Professor Noakes, I've spent hours with him and you go, man, what an honor. Gary Fitke and what they went through. And so many people that are, and really the most important thing is hearing the patients' testimonies and stories of what they went through, of being 400 pounds and wanting to kill themselves. And now they're out helping people. And we had a part in that. It's pretty amazing.
That's pretty cool.
Well, someday we'll be like you guys someday, maybe, if we keep fighting along.
What's the name of the podcast again?
Low Carb MD and Life's Best Medicine is mine.
Low Carb MD and Life's Best Medicine.
That's right. You enjoyed it so much, you decided to start a second one as well. So
because, that's funny because on Low Carb MD, they go, just talk about low carb. I'm like, there's more to the story. Stress, sleep, all these things we're talking about. Those things play a huge role. If we neglect those things, like we're missing out. So if faith is important to someone, cool. If collecting rocks or yoga or wherever you find your peace. And that's why I did Life's Best Medicine. What's life's best medicine for you? What really matters? That's what we all have to figure out for ourselves at some point. And so you hear these stories of people that like were on death's door and they turned it around. You go, man, it's amazing. How did that person do it? Then if that person can do it, that gives someone else a hope, right? More so than us talking about the latest literature all the time. Yeah.
I'm glad you're in Arizona. I'm glad you're just up the road from me. Phil, I don't know if I told you this, but Brian and I and our wives actually, we have breakfast together?
Yeah. I got a free breakfast out of Jack. That was nice of him, really. Yeah, that doesn't happen.
So that was that bill that Jack sent me the other day.
Yeah, that's it. Yeah, that's it.
Come on now. We are thrilled to have you back. We're thrilled to circle back around. But I think above all else, for me, the most extraordinary thing is to realize what a tremendous impact you guys are making. Both of you guys, Dr. Ovadia and Dr. Lenzkes. When Phil first asked me to help him with this podcast, I had no idea. I just was, okay, I produce podcasts. Sure, I'll be happy to do that for you. I was just doing a buddy a favor. And it has been so much fun to watch the world begin to catch up with the realities of our screwed up medical system and how to be metabolically healthy. And I think you two guys have both had a pretty significant role to play. I would like to ask a specific request here. There's going to be healthcare practitioners who get forwarded this particular episode. They're going to have patients who are going to say, hey, you should hear this guy. You should do what he does. And then they're going to want to know, okay, what do I do next? Let's send people places that help them to help themselves exit the system.
Yeah, definitely. One I'll start off with is the Society of Metabolic Health Practitioners. I know it's an organization that Brian Tro and many others have played a big role in, and it really can be the gateway, I think, to open up to this world and it's empowering physicians to do this, right? Because it's, Brian mentioned earlier what it takes, right? And you have to be courageous and brave, but doctors aren't used to being on their own island, and having a community of physicians, of practitioners of all sorts, but physicians that are doing this is key. And that's what the Society of Metabolic Health Practitioners is doing, to allow us all to fight this fight together.
Yeah, I would agree. There's so many great resources out there. It's funny. I just glanced up, happened to be sitting here. I was like, okay, there's one, Practicing Excellence, and there's Direct Primary Care. And I was like, okay, let me read this book and see what I got to do. And I knew I was done. And so the thing is, there's Direct Primary Care Alliances. There's so many direct primary care groups. those people loved on me. They taught me, they explained the ropes. How does this work? How does that work? And they have time to do it. The rest of us, that's why a lot of the people in the standard care, they don't look at low carb. They go, it's a fad that's going to pass. I'm not wasting my time. I don't have time to deal with that. Right. But they don't look at the data and the research and all the studies that are out there. And if you have the time, take the time. And those of us in direct primary care have more time to help invest in it. I had 2 doctors call me in the last week, go, how do I get out? I can't take it anymore. I was like, we're saving lives. We're saving doctors' lives. I think it's 3 times it's either 2 or 3 times the national average of suicide as physicians. Our best and our brightest are killing themselves. There's a reason for that, right? They can't take it. They went in to help people with their nice white coat, and we're walking in and we're going to cure all the disease. And then we realize we're really not helping people anymore. So if you're in that situation, take a breath, look and say, hey, can I survive doing this? Can I call another buddy and we do it together and we share the cost? There's ways to get out. But I think it's like being a prisoner, you have to get out. You can't stay in there if you're miserable. For me, it was like just one more year, just one more year. And then you go, okay, now I got gray hairs and I'm beat up. But yeah, those things, it's really just having the courage to step out and cut your expenses. Don't buy the fanciest cars. Keep your life expenses down. You don't need all that stuff. You need your family. You need friends and loved ones around, and you need to provide good care. That's why you went into medicine. So it's going to be, you have to get a loan, whatever you got to do. I paid back all my loans in the first year of my new practice. Arizona's going to take a little bit longer, but that if you're doing good care, and the reality is word of mouth gets around. And if you help, all I need is to get a few patients in and they're going to tell their neighbors and friends, they go, your doctor calls you, your doctor cares. They know your name. They know about your kids. The staff is friendly when you go in. That's what I want. So most direct primary cares for patients cost $100 a month, like $1,200 a year. And you have state-of-the-art care. And if you have a higher deductible, that pays for it right there. And so there's a lot of good plans out there. And so it's just making it work. It's really, and I think when the direct primary care are advocates for their patients and they can say, hey, look, I have 300 patients. How much will you give me an MRI for, a CAT scan for? Can you make my patients a special deal? And there's stuff we can do to make the system work. Because as a personal example, I'll tell you guys, my daughter, who's a teacher, went into the ER with some abdominal pain and ultrasound, 3 hours in the ER, $11,000 bill. Her copay, $4,000. Look, I could have saw that. I could have saw her, like I was traveling at the time, but I could have saw her obviously be free. But if she was one of my patients, it wouldn't cost her anything. I get an ultrasound, we get it done and figure out what's going on, get some labs and figure it out. So it's a tragedy for people, man. That's crazy. It doesn't cost that, right?
No,
so
it does
yeah.
not.
So I think as we all put our minds together, we get this system together. It's just hard to get us doctors to work together to rebuild. But I think individually, as we group and we do this, we can help other people for sure. Because I could bring someone on, Phil could bring someone on to help him, and we get to go home a little bit earlier every once in a while. It's definitely, there's definitely a need, and we just got to change the system. And I think you're right, Jack, is that seeing it in the public eye and the political eye finally, it's a huge deal. I think people realize who was dying of COVID was the metabolically sick, morbidly obese, and diabetic. It's not politically correct, but that's what it was. That's the facts.
Yep.
And so you go, okay, how many of my patients, knock on wood, got admitted? 0. How many died? 0. And you go, why? Were they metabolically healthy, or was that a factor? Or am I just that great of a doctor? But it's really, if you're metabolically healthy and if we address these things, people aren't sick. No one wants to be sick and miserable all the time and just throw another drug at everything. Yeah. I want to be like Dr. Phil one of these days. It's exciting, but it's exciting to see it. You're right. Coming around that we put our careers on the line because it was malpractice to talk about cutting processed foods out a couple of years ago. That's how far we've come.
That's what amazes me is when I look back and when Dr. Brian Lenzkes first appeared on Stay Off My Operating Table, it looked to me like we were trying to push a boulder up a mountain. And here we are 2 years later, and it is astonishing how far, not just this podcast, I never in a million years would have thought this podcast would be as popular as it is, but the number of people who get it now, the number of people who are talking about it. Tulsi Gabbard is talking about metabolic health and seed oils. So let's keep pushing, guys. We're changing the world.
Keep up the good fight. Keep up the good fight. You guys, thank you so much. I'm excited about what you're doing. Congrats on being around and growing and doing all this. And yeah, I'm just jealous of Jack's voice. You have the perfect podcast voice, man. He got it all.
Yeah.
And
Well,
he has the looks for TV too, for people who are just listening.
Okay, enough of that. Our guest has been Dr. Brian Lenzkes. He co-hosts the Low Carb MD podcast with Dr. Tro Kalayjian. And the other podcast is
Life's Best Medicine.
Life's Best Medicine. Recommend them both. And if you happen to be in the appropriate county in Arizona, you might even be able to put him on your board as your physician. So we'll make sure contact information for Dr. Brian Lenzkes is in the show notes. Phil, this has been really fun. I appreciate it, man. Thanks.
Definitely.
Thank you, guys.
All right. We'll talk to y'all next time.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Avedia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.